This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Roman Skoracki. Roman is the medical director of the Stefanie Spielman Comprehensive Breast Center, and he also leads the James Division of Oncologic Plastic Surgery. The Spielman is one of the largest and best medical centers devoted entirely to screening, diagnosing, and treating women with breast cancer. Roman will fill us in on what he and his team do, the great advances that have been made in treating breast cancer, and he'll also fill us in on what's next. Welcome back to the podcast.
Thank you for having me. Thank you very much.
So the last time you were on, you were fairly new as the medical director of the Spielman, so you've had some time to let some things sink in. What's it been like the past year?
Drinking from the fire hose still, I think.
Still?
It still seems very early on. I think it's just such a large center. There's so many things going on, so many exciting things going on, so many people. So it's constantly evolving, which makes it incredible. And so just a great place to be part of. And so that's why I think to truly comprehend the breast center will take a little longer, but I think I'm starting to get a good handle.
Okay. And you said that whole concept of large, it's one of, if not the largest centers devoted just to breast cancer in Ohio and beyond?
In the Midwest, we're the largest freestanding comprehensive breast center in the Midwest, yeah.
So having that sort of all-in-one center where women can come for many different procedures in one building devoted just to that, how does that sort of help patients like mentally and also in terms of their treatment outcomes?
I think it's tremendous. I mean, I think all of us in the center, we believe, in this concept. I think it's incredible for so many reasons. As you mentioned, it's a cutting edge place. I mean, there's innovation. We have innovation in screening and treatment. We have some of the latest and greatest technology available to us. But at the same time, it has that kind of almost familial feel, and everybody is under one roof, which really kind of helps us communicate about the individual patient and really kind of tailor their treatment and their experience, which is what we do on the phones with email constantly all day long. But then it goes beyond that because you're constantly because we're with each other, it's easy to raise a question. It's easy to come up with that research idea with the clinical problem that we don't have an answer to, and then you bounce it off a colleague. And so it's a very kind of symbiotic place from a clinical, from an emotional, but also from a research point of view, and it makes it, I think, makes it very special. That
concept of bench to bedside is it works easier when the person on the bench
Absolutely.
Is in an office next door to a person who takes care of patients on the bedside.
Exactly, like so many things. I think if you know that person's face, you know not their name, you know a little bit about them, and it's just so much easier to pop in and exchange ideas, exchange thoughts, and that's absolutely the case for us. Yeah.
How many people work at the Spielman?
There are over 340 people that work in the Spielman, and it includes everybody, and everybody is an integral part of making that program work and make it work as well as it does. Yeah.
Okay, and so the idea today is for you to tell people here in Columbus and beyond all the great things you're doing. And I guess as we've talked before, sort of the foundation of breast cancer treatment is early detection through screening.
Right.
So what are some of your advances and techniques and just the importance of breast cancer screening?
Yeah, absolutely. I mean, I think that the screening, as for so many cancers, is just the early detection and then the being able to intervene early. And we talked a little bit about prevention as well. Just identifying those families or those patients that may be at high risk that may not have cancer yet, but plugging them into the appropriate program. And we certainly have that within the breast center. And then being more aggressive, more vigilant about the screening and kind of discussing options for them for their treatment. And that may include just observation and very close observation as they're going through family planning and building families and maybe not having to intervene, but maybe certainly wanting to intervene before a cancer occurs. But then that falls into that screening part where we have available not only within the brick and mortar of the Stefanie Spielman Center, but now with the satellite clinics that are available and satellite imaging facilities that we have available, where our technologists and our radiologists that are breast specific will actually staff these around the city and to provide a tremendous amount of access for patients to be able to get screened and then obviously go on to diagnostic imaging if necessary.
So you have centers all over the city because some people have difficulties getting places, and you also have a mobile mammography unit.
Absolutely correct.
That goes all over the state and serves underserved populations.
Yeah, and we try to meet the patients as close to their home as we can, because we do recognize that it is difficult to drive and it's difficult to to get appointments, to find parking and all those things. So we do want to make it as easy for the patients as possible, and that includes the mobile mammography unit that goes all the way into Appalachia and really tries to serve communities that have little or no access to some of the technology that we can bring to their communities.
Yeah, you brought up a couple things I want to follow up on starting with that, the mobile mammography unit and reaching out to underserved populations. Mm-hmm. That's become a term that's become more in the news lately, but you've been doing it for a long time, reaching out to urban centers where women may not have, due to socioeconomic problems, may not have access to mammograms, or in rural Appalachia there just isn't a center within 100 miles of where they live where they can get screening. You meaning the James and the Spielman, have been doing this for a decade or more.
You're right. Yeah. It's been going on a little over a decade, and we, in fact, we just had a meeting about it today where we identified some of the hurdles that patients may encounter that may be socioeconomic and maybe just distance, geographic distance, but we find patients with language barriers, with cultural barriers, and so we're making every effort in trying to include those patients, reach out to those patient communities, and allow them to kind of, I guess, feel the warmth of the Stefanie Spielman and try to get to them and bring them in through screening. Hopefully, not have to treat, but if necessary, absolutely, we're available to treat those patients as well. And we're trying to get that word out, make sure that everybody knows that is available, and we're constantly kind of trying to send our feelers out further to make sure that nobody is left in the dark, so to speak.
And the other thing you said I wanted to follow up on is this high-risk, I'm not sure the exact term, high-risk breast clinic, but there are women who have certain genetic mutations, a family history. They need to be watched really, really closely. So what exactly is the high-risk clinic that?
So the high-risk breast program is really a program that, exactly as you noted, tries to identify women, and usually it is found through a family member that was maybe diagnosed at an early age. So anybody with an early diagnosis of breast cancer will be offered genetic testing, and so then obviously we reach out to the remainder of the family and we offer programs to identify who is at risk. They may not all be at risk, but then absolutely genetic counseling, genetic testing will be performed and will be offered to those families of other family members. And then we have a clinic that specifically follows those patients, and that hopefully we're finding the majority being introduced to the majority before they develop a breast cancer. And then, as I mentioned, we would follow them very closely, and then there's a lot of discussion about kind of timing of preventative interventions, usually a surgical intervention for breast cancer to perform like a prophylactic mastectomy, for example, would be an example. But again, that's not something that maybe a 20-year-old may want to face, and doesn't necessarily have to face. Right. But it requires a comprehensive program to kind of walk the individual patient through those choices and find the right timing, right choice for them.
So I know of a little bit of the BRCA genetic mutation, and if a parent, a mother or a father has it, perhaps their children can get it, and that's why you need to do genetic testing on siblings, family members,
exactly
to
correct.
Catch everyone.
Exactly correct. Yeah.
And then screen them to catch it at the earliest stages when it's really...
Or ideally even before the cancer's developed. But so, for example, as you mentioned, the BRCA1 and 2 mutations are probably the biggest ones for breast cancer. And those have lifetime risks between 40 up to 60-70% of developing a breast cancer. And so those patients we want to identify absolutely before they develop a breast cancer so that we can plug them into these programs. And then we have, absolutely fantastic genetic counselors available that will walk you through all of the, I guess, all the considerations that come along with that diagnosis, because it may not only be breast specific. In fact, often it isn't. And so then we have this program that will absolutely plug the patients into the right resources.
So are you saying, when you said you can detect it precancerous, is there something sort of like a precancerous polyp in the colon that can be removed? Is there something in the breast that's similar to that?
Not exactly. So what we would rely on is that really that genetic signature, the mutation that we're looking for. But then we would look at the breast with our screening tools very carefully and hopefully find that there is no breast cancer present yet. But then we would offer that woman or the man the ability to kind of choose and weigh their risks, decide when maybe it may be time to perform a prophylactic mastectomy. Again, to go through maybe some childbearing years, maybe breastfeeding, before considering removal of the breast prior to the development of a breast cancer.
Right. That's what I've heard, that women tend to want to have children and wait. And so they're 35, 40, and then they reduce their cancer risk through what you just described. Wow. And you also mentioned, you said women and men, and that's true. A much, much smaller percentage, but men can develop breast cancer.
Absolutely correct. Absolutely correct. And again, as you mentioned, with the families, we wouldn't only test. I mean, we'd absolutely extend that to the male members of the family as well for that very reason.
Yeah, one of the docs in your center, we did a podcast, and he said he has the BRCA gene, and he gets tested.
Correct.
And so, knock on wood, if it ever develops, they'll get it super early.
Right.
So, okay. So, a lot of places all over the country do mammograms.
Yeah.
And it's not, black and white. It's a bit of an art form. It's a craft. It takes expertise. So what do your people who read mammograms and what makes them so good at it?
Well, there's so much to talk about here. I'm so excited about that, and I really should have probably one of our mammography folks here. So I think on a very basic level is that our mammography staff, our diagnostic imaging folks, are all dedicated 100% to breast imaging. So that's what they do day in, day out. All modalities, ultrasound, obviously mammography. ABUS.
What's ABUS?
So this is this very, very high-tech ultrasound looks. We have the 3D mammography. There is Clarity HD to look at breast imaging now.
That's the one that takes it like it moves around the breast, so you get like a 3D image, so you get even more definition.
Yeah. So I think we have multiple things. From on one end, we have imaging specialists that really are dedicated to only breast imaging and looking at breast imaging, examining breast imaging day in and day out, and so they've just become incredible experts, super experts at this. Then we also have an incredible array of technology available at their fingertips to look deeper into something. To first of all, to get the best images that are available currently, but then also to probe further if necessary. And then within that group, even there's a huge interest in using AI, in kind of combining multiple AI technologies to even augment this expertise further. And I think all of these things are just incredibly exciting.
I've heard about that, how they're using AI to help technicians read mammograms and other types of screenings better. How does that work?
So I find it fascinating too, and I should probably not even speak. I should have Dr. Taylor speak about this, one of our AI specialists. But my understanding he gave an incredible talk very recently to the group, is that there are multiple tools available where the computer essentially is trained to examine these images and then hone in on anything that may look abnormal, and it learns over time what the abnormality is, guided by the radiology experts. And my understanding is that not one platform really is ready for prime time necessarily, but that they're actually combining multiple of these reading technologies now, and that enhances their accuracy. And so somewhere I think we'll probably find that with the help of a highly trained radiologist and these platforms, that might make reading many of those scans faster, easier, and probably more accurate.
So it's one more tool for the radiologist to use.
Exactly right.
But still, his or her skill and experience is the biggest factor.
At this stage, yeah, it's unequaled. Yeah.
So we're going to take a quick break, and then when we come back, we'll dive into an area that perhaps you're pretty familiar with, since you do it every day, and that's treatment and surgery.
Absolutely, let's do it.
You didn't choose cancer, but you can choose where to treat it.
And when you choose the James at Ohio State,
you're picking a team of experts who understand there is no routine cancer.
You're opting for care from a highly specialized team dedicated to treating one type of cancer, yours.
A team that studies the unique makeup of your disease to develop a personalized treatment plan.
You're choosing our region's only comprehensive cancer center designated by the National Cancer Institute.
Where more than 1,700 scientists are working on new treatments and new hope for every form of cancer.
At the James, you're making the choice to have the most advanced treatments, many of which were developed right here.
And you're choosing access to the James world-class clinical trials, dedicated support services, and an unmatched survivorship program to support your life after cancer treatment.
You didn't choose cancer, but the choice of where to treat it is clear.
We're back with Roman Skoracki, the medical director of the Spielman, and he gave us a great overview on screening and diagnosis, and now treatment, which is what you do on a daily basis. But there's, you do 3 or 4 types of treatment, but there's so much treatment and so many different treatment options, and they've advanced so far. And this could take hours, but you're good at synthesizing. So let's talk about treatment. Where do you want to start?
Well, let me try to distill. I don't know if I can either.
Yeah,
but
I put the pressure on you.
Yeah.
Here, I'm looking at my watch.
So the treatment, it really involves all the subspecialties. And so we'll have our medical oncologists, our radiation oncologists, certainly our surgical oncologists, and then our plastic surgeons all working together. And you really need to individualize that approach for every patient and for every tumor. And it's not we're not just treating the tumor. It's the overall picture. So many things come into that decision making. So many factors.
Now wait. The 4 things you said. The medical oncologist is sort of like the quarterback for the patient who guides them through.
I like to think we're all the quarterbacks.
Okay. All you surgeons always think.
That's right.
But that's the person. That would be the person the patient would meet with, and who would kind of oversee their treatment and give them their perhaps chemo or immunotherapy. The surgeon does surgery.
Right.
The radiation oncologist provides radiation, and the plastic surgeon, which is what you are, is a vital in rebuilding.
Correct.
And also preventing or reversing neuropathy.
Correct. And so I would say that probably the first person that you meet, so I don't know that's maybe not the quarterback, maybe the linebacker, I don't know, but first person you meet is your surgical oncologist. Will be kind of the first handshake with the program for most patients.
Okay.
And then it may very quickly shift. Certainly our medical oncologists will be the ones that you spend a good 6-7 months with if you require chemotherapy, but there is a fair number of patients that may not. And so it's kind of a little bit like a menu where, some of those folks you will meet, some of them you may meet once, but then may not require their treatment.
You may not require plastic surgery. You may not need radiation.
Correct. Exactly right.
So,
exactly,
but those are the 4 sort of main physicians
standing by to assist and to kind of create that treatment plan for the individual. We talked a little bit. Certainly, other surgical oncologists, there to do either partial removal of a breast or complete mastectomy, complete removal as necessary, and then also sampling lymph nodes and either just one or two, or maybe having to take the lymph nodes if there's some involvement in the axilla and the armpit. And so that's kind of the I would say the upfront core treatment most of the time. Now, sometimes what we end up doing is that folks start off with our medical oncologist, that what we would call the neoadjuvant chemotherapy treatment, so upfront chemotherapy. And we usually use that if we feel that we may be able to de-escalate, that we may be able to do a little bit less surgery than we would have to upfront, because some of the tumors just respond so incredibly well. And so there may be there's different parts of this equation you'll meet at different times, and in the end they will all come together to kind of create that perfect treatment plan.
Is that something that's changed in the treatment of breast cancer over the past 20 or 30 years? That, and correct me if I'm wrong, of course, but previously the initial thing was just surgery right off the bat. And now, with the development of chemotherapy and immunotherapy, you're doing that first to either shrink or sometimes get rid of the tumor. Is that happening more?
I think that's a very appropriate statement. Yeah, I think there's been an incredible change, a shift from in kind of incorporating these different modalities at different times now, and it's very dependent on the type of tumor, and then very dependent on the chemotherapy that's available for specific receptors, for example. And you're absolutely right. The combination of chemotherapy, immunotherapy, these very targeted therapies for specific messengers of individual cells, and all of these things are coming together now, and it's from a treatment point of view, a very exciting time, because so much has happened in a very short period of time. And so that translates into this more neoadjuvant approach for many patients, where we take a tumor, or the lymph nodes are a prime example, where if there is an axillary nodal involvement, where we know that there are tumor cells in the lymph nodes of the axilla, traditionally we would have had to remove all of those lymph nodes, including the surrounding normal ones, because we wouldn't have known which ones are normal or abnormal. Now, with the neoadjuvant chemo, especially if a patient responds remarkably well, and we can see that potentially in the primary tumor with shrinkage or almost complete, if not complete, disappearance, and that will often be mirrored in the lymph nodes as well. And so rather than having to take all of the lymph nodes, we may be able to just take 2 or 3 of them, find that all we're seeing on pathology then is dead tumor cells in that lymph node, and that gives us a greater degree of comfort of leaving the remaining lymph nodes behind, knowing that the treatment has been very, very significant and has been complete.
Now, I've learned about lymph nodes from you and the word axilla, which is armpit.
Right.
And you have your lymph nodes in your armpit, which are the body's drainage system.
Right.
And it's also where the cancer cells spread. So just to explain this to people, so if there are cancer cells in the lymph nodes, that means it has or could spread throughout the body. But if there's not, or if you've treated them, then you can remove less, which reduces the possibility of neuropathy.
The possibility of lymphedema.
Lymphedema.
The swelling.
I'm sorry. Neuropathy is the foot thing. I'm sorry.
Neuropathy is the sensation.
Yes,
the loss of sensation.
Lymphedema is the swelling of the arms or the legs.
Exactly right.
Where you're an expert in that type of surgery, connecting the nerves and reducing that.
Yeah.
I'm sorry.
No, that's perfectly fine. So we're trying to avoid, again, I'm trying to put myself out of business, really. We're trying to avoid
by taking less lymph nodes out.
Exactly right.
You can.
Exactly right.
And that leads me to think that, again, caught early, it hasn't spread to the lymph nodes. The success rate is like way over 90%.
Correct.
But what happens in women that you don't catch it early? It's in a late stage and it's gone, the cancer has gone into the lymph nodes. What happens next that makes breast cancer deadly? Because it's not something that happens in the breast that kills a woman. It's where it spreads and does the damage, right?
Correct. And you're right. I mean, the generally speaking, the first point of where cells may be caught, where they may be filtered, is the lymph nodes in the armpit, and so that's why it's almost like a surrogate. If you don't find any there, the chances of finding cells elsewhere in the body is very, very slim. But cells can certainly go beyond, especially if there's actually nodal involvement. Cells can go and they can spread throughout the body, and so they can go to the lungs, brain, bone, and so that's usually the more morbid stages of late stage breast cancer. Again, I think that you alluded to kind of the chemotherapy advances and immunotherapy advances, and we're finding that there's a tremendous shift, that there's just even with disease beyond that, with metastatic breast cancer, that survival and quality of life has improved dramatically. Yeah.
Wow. And continuing to improve.
Correct. Exactly right.
Well, that leads us to another area which is becoming more and more important: survivorship. People who are going to live cancer-free or with cancer for extended periods, and that's a new term that you're hearing more and more. What does it mean, and how do you apply that to help patients?
Yeah, survivorship, I think, is a great term. It's a little bit of a tough one because it's a little bit of a grab bag, I think, for many things right now. So survivorship to me is in one area is kind of more the ongoing active treatment of someone with breast cancer. As you mentioned, is we have patients that have metastatic breast cancer who live for years and we live for decades with active breast cancer, but the ongoing treatment, ongoing therapy, these immunotherapies, AIs, and all these types of different drugs that are available now.
You said AIs?
Aromatase inhibitors.
Oh, okay.
Yeah, so these different drugs that are available that will essentially kind of keep the tumor at bay, will keep the tumor cells from spreading, from growing, are allowing patients to have very high functioning and high quality of life for many, many years. And so that's, I think, one part of survivorship. And we certainly have multiple programs within that, and our medical oncologists all have their special interests in different tumor types for that. But then and that includes also, for example, our kind of living well with advanced breast cancer clinic, and we put on kind of annual conferences for patients with that to keep up to date with kind of the newest advances. And so that's, I would say, one part of survivorship. The other part of survivorship is really looking at quality of life, enhancing quality of life, not necessarily even in someone with ongoing or metastatic disease, but in patients that are survivors of breast cancer that have no evidence of disease, but that have this journey behind them, and now are just trying to regain a sense of normalcy and kind of re-engage with their normal lives. And so we have a tremendous number of programs that are available for that, and they are physical, emotional, gardening, all of these different survivorship programs that I think also fall under that umbrella. So I think it's a grab bag of many, many things. Sexuality and learning about kind of maybe a change in sexuality with hormonal changes, and all those things are part of that survivorship journey that we would love to support for patients.
Yeah, as you're speaking, I'm thinking that's another thing that's changed in the last 20 years, that cancer centers, cancer hospitals take a holistic approach, and it's not just treating this patient's cancer and cutting it out and giving them drugs. It's their whole life, and how do we help them with every aspect of their life by providing programs to bring women together, to teach them, to give them some joy, to have them involved in activities. It's just bigger than surgery and drugs.
Absolutely. And I think the recognition, and you pointed this out, is that the anything we do will have some type of an effect on the the person, on the individual, on the biology that is that individual. And so I think we spend a lot of time and effort in trying to normalize that, or finding ways to really kind of bring that individual back to their normal functioning status, to their normal way of enjoying life.
New normal.
New normal, yeah.
Your life has changed.
No, you're right.
Yeah.
You're absolutely right. Yeah.
So, that's a lot. And there's only one.
And we're just scratching the surface.
I know. All right, should we make this a weekly thing then?
Yes, I think we should. I would love to bring in some friends. We could highlight so many things.
Well, when we're done recording, you're going to give me a list of 3 or 4 people.
All right, I would love
on your
that.
team that I should do future podcasts for.
I would love that.
And we'll do that. Because you're right. It's you are the quarterback of this giant team. But you have a lot of people on your team doing great work.
Absolutely.
But give me 1 or 2 sort of new cutting edge things that have started in the past few months that you're excited about.
I think one program that one of our, actually, again, it's definitely a team approach that was recently started, is our inflammatory breast cancer program. And this is specifically designed for patients who present with inflammatory breast cancer, which is a very aggressive form of breast cancer. Whereas in other forms of breast cancer, kind of the treatment course from presentation to treatment can easily take weeks to even a couple of months, which is absolutely safe because it tends to be a much more slow-growing process. In inflammatory breast cancer, we don't have that luxury. It's a process that evolves within weeks.
What is that inflammatory breast cancer?
So it's just it's a specific type of presentation. It's not as though it's a different type of breast cancer. It is a breast cancer. But it just presents differently. It presents in a much more aggressive way. Usually, commonly, it presents with a swollen red breast, something that it almost mimics an infection, a breast infection. And so it's very difficult sometimes to tease that apart until you have appropriate imaging and investigation done. So that's a situation where we need to take the entire infrastructure that we have available and really kick it into high gear. So it's a program where if we hear about that patient, we will reach out, or if the patient comes to our diagnostic center, to our screening center, and everybody is in tune to this. Everybody will identify that patient quickly, and they will be in a treatment situation within a week. We'll have them see our specialists and work them up within days, and they will start treatment within a week or so.
Because if their breast cancer is growing faster, it's going to metastasize faster and
exactly right. Yeah, the spread. Yeah.
And again, this is a perfect example of why you want to come to the Spielman, a center devoted just to breast cancer, because some other places may see this once every 5 years. You see this all the time and have doctors that know exactly what to do.
Yeah, and I think especially with this program now, I think that our colleagues around the state are very much in tune with that now, and also know that they can send those people to us, and that we have the infrastructure to kind of mobilize the troops very quickly and have them taken care of. So that's a really exciting program. We're very thankful for everybody who's part of it, who's ready and willing to add that patient in immediately into their clinic that same day and look after them. Another thing that we're excited about is we're working on building a program specifically for patients with brain metastases. So obviously very specific needs, very specific needs from a support point of view, but also from a care team point of view. So we're bringing in kind of specialists in neurosurgery that have a special interest, our radiation oncology folks, our medical oncology, and so we're building a program that kind of brings all of these specialties together, also from a research point of view, and really advances the care and then the innovation around that.
So when you say brain metastases, this is breast cancer that's spread to the brain.
Correct.
And even though it's cancer in the brain, genetically it's breast cancer and has to be treated as breast cancer.
Yeah, from the cells that are causing it have come from the breast. They're not brain cells. They're absolutely breast cells. Yeah, you're absolutely right.
And how do you treat that? What are some of the advances that are hopefully...
So, and generally speaking, that's why I mentioned those three specialties. It's usually a combination of therapies, either surgery, usually combined with radiation, and absolutely always combined with chemotherapy as well.
Now, would that be something that one of the surgeons from the Spielman would do, or one of the surgeons that are more...
So one of the James,
okay,
that would be our James neurosurgeons.
Yeah, because surgery has become so specialized that someone who's a breast cancer surgeon specialist is not going to be the person you want in the brain, and vice versa with the neurosurgeon.
That's correct.
It's become so specialized, and again, why you need to go to a comprehensive cancer center.
Absolutely correct. And I think it is still important, or particularly important, that there is that talk, that we have that luxury of being in the same building, but by building these types of programs, there's constant exchange among the members, and so that's where you really move treatment and innovation forward.
So I take it that what you just said, innovation and moving forward, is what drives you to keep doing this. So is that true? What does drive you to see patients, operate on patients, be the medical oncology surgical director, to be the medical director of the Spielman? What drives you to do all this?
I mean, it's absolutely the patients. It's our patients, and then my colleagues. I mean, I can't overemphasize. I think it's really that family feel, and I think certainly my colleagues, I feel like, are part of that family, very much so. But then also the patient becomes a member of that family, and so I think you have that more than intellectual sense of responsibility. Is very much an emotional attachment as well, where you really don't want to let any of your family members down. You really want to push that envelope. You want to give them the very best and try to figure out those things that where you may not have the answer to. And then it's nice to have that group around you. We can all, work together and bounce ideas off each other and really kind of move things forward.
Okay, well, Roman, thank you again for sharing all this great information and all the great work you and your team of 300 plus amazing doctors, technicians, physical therapists, nurses, and so on are doing over at the Spielman.
Thank you for having me. It's an absolute joy, and it's a pleasure to be able to brag a little bit.
Okay.
Thank you.
Feel free to brag anytime you want.
Thank you.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.